here. And just a big welcome to the second webinar in our Living Safely with Dementia in the Community series. Today's focus will be on interactions with paramedic services and ER visits. My name is Susan Oster. I'm a public education coordinator with the Alzheimer's Society Southwest Partners. I will be the MC and moderator for today's webinar. Danielle Belais, another educator with the Society, will provide technical support today. At the Alzheimer's Society, our role is not only to provide programs and services for people who are going through the journey of dementia, but also to provide dementia education and to advocate for those living with cognitive disabilities. So before we start, I have a little business to go over relating to the webinar experience. So please note that your cameras are off and microphones are muted for the webinar. This event is being recorded and will be available in the future on the webinar page of our website. And what I typically do for anyone who has registered for the webinar, once that becomes available, you'll get an email to let you know that the recording is available to view. At the end of the presentation, we will have about 10 or 15 minutes for moderated Q&A, and we will do our best to address as many questions as we can. During the presentation, if you think of any questions for the panelists, please add them to the Q&A box located at the bottom of your screen. So there's a little picture of it there. If you would like to submit a question anonymously, please click the Send Anonymously box before clicking the send button. Should you have any technical concerns, please type them in the chat box and my colleague Danielle will be happy to help you. You may need to move your cursor around a little to see the Zoom controls and icons. And so again, technical issues in your chat box and your questions in the Q&A box. All right, my notes here, turning the page. And we have also enabled a really nice feature called the upvote feature in Zoom, which allows people to see all of the questions being asked and to move the most popular questions to the top of the list, which really helps me as a moderator to make sure we're addressing the most urgent questions. So if you see a similar question posted by someone else, you can simply vote on the question by clicking the thumbs up icon underneath the question. So as you see there, and then once the icon is clicked, the question will move up the list. So I'll see those ones first. And just a quick disclaimer, since everyone's situation is unique, the information being provided today in this presentation is for educational purposes. So should you have any specific questions about your situation, please contact your healthcare provider or your support worker with the Society. So now I have the great pleasure to introduce and welcome our panelists. So Lindsay has been working in various roles in emergency services for over 17 years. Currently, she is the manager of Community Paramedicine Program for Elgin St. Thomas EMS. Her background and training is as a primary care and community paramedic. Kim Snell, who is sitting to the right, has been working in Elgin St. Thomas as a primary care paramedic for 32 years. So Kim, I'm guessing you started when you were what, 16, 15? Okay, good. And she now brings this experience to her role as a community paramedic. And Jackie, at the bottom of the headphones, is a BSO, Behavioral Supports Ontario social worker with the Alzheimer's Society Southwest Partners, and she is based in our Elgin office. She is coming up on her first year anniversary with the Society and is excited about what year 2 will bring. Jackie chairs the Committee for Elder Abuse Elgin and is passionate about supporting the marginalized in the community. And Jackie has worked extensively around London and St. Thomas in mental health and crisis work and currently does relief work with CMHA TV. Keep adding extra letters to their name at the Elgin St. Thomas Elgin General Hospital and the Unity Project for Homelessness in London. So I know I've actually heard Jackie a couple of times on CBC radio talking about some of the great work that she's involved with. So with further ado, we'll jump in with our topic for the day, and I'm just going to stop sharing my screen. Okay. So Jackie, I'm going to have you start. You're going to share a bit of a story with us, and then our panelists will sort of speak to that story and add a little bit more information.
Thank you, Susan. And I'm just going to preemptively say I do have a cold, and if you can't hear me, I apologize. My voice has been going in and out all day. So without further ado, I am going to just jump right into this scenario. I do take it from personal experience. It's one I had with my mother, who was living at home independently and had been diagnosed with a dementia already. Home and community care supports were in place, very minimally at that time. So I was at work and I got a call about my mom from the PSW who was visiting. It would appear that my mother had taken all of her medications from the Bliss Pack. This was indicated as they were there daily just to check in on her, and they had happened to check the day before. Medications hadn't been taken. 24 hours later, all the medications were gone. We know that there were some medications in there that we couldn't take any chances on. So a trip to the hospital is what was necessary. I couldn't leave work at that time to attend to my mother's home. I had to wrap some things up. So I asked the PSW to please call 911 and have them take my mom to the hospital, and I would meet her there. The PSW reported to me via text while she was on the phone with 911, when the paramedics arrived, that there was no way my mom was going anywhere with them. She didn't know them. She didn't trust them. We obviously, and honestly, we weren't prepared for a call like this. So however they managed to do it, the paramedics worked their magic, and they were able to get my mom to the hospital on the ambulance and to the hospital. When I arrived, now, so this was pre-COVID, and when wait times weren't as lengthy as they are now. And so when I arrived at the hospital, my mother was extremely agitated. And this was at the time that they were implementing the bracelets to indicate different levels of agitation and aggressiveness. And they were about to put one of the high risk bracelets on my mom, who honestly wouldn't have hurt a fly. She was all bark and no bite. So I was able to, and she was very confused and very afraid, obviously. And so I was able to I asked the medical staff to just let me talk with her. I was able to get her calmed down and explain to the staff at the hospital what had happened, that she had a dementia, that I am her power of attorney, her initial care partner or care person, and what had happened. And so when I did get there, Mom was in the hallway with the paramedics, who then disengaged when I got there. As I said, this was pre-COVID, and so wait times weren't as lengthy as they are now. My mom was pretty quickly, like I would say within an hour or two, probably closer to 2, taken in to a smaller area, now trying to keep somebody who's got a dementia, who may or may not have taken too many medications, trying to keep them occupied while we're in a busy waiting room can be a challenge. And so thankfully, Mom really liked looking at cat videos on my phone, which we did. I had the foresight to have that. And so when she was initially assessed by the nurse asked the questions. I said nothing. And my mom was fine. She said she was fine. And that's when I had to intervene and say, no, we suspect she took all of her medications. Here's the list. And that's why we're here. Mom had no recollection of that. Doctor finally came in and understood what was going on. I had to advocate quite heavily several times to say, no, she is not fine. You need to listen to me, please. She's my mom. She's terrified because she's here. She's confused because she has a dementia. She's not angry or aggressive. she's confused and afraid, and we think she took all these medications. Can we please focus on that piece? Because they kept trying to focus on the, oh, she's confused and afraid and she's angry. So I had to keep bringing them back to the reason that we were there. And advocacy is a strength of mine, so I kept them pretty focused. So finally, the doctor came in and recognized what was going on and called in home and community care supports right away. And they did not, they would not let me, they would not release her from their care without a plan in place for medication. So I had to write a detailed explanation of how we were going to make sure that mom didn't take her medications, and they had to step up and put support in place twice. Well, it was supposed to be 3 times a day, but they were able to change some of excuse me, change some of the medications to twice a day. So that they could send PSWs in twice a day. I had to buy a safe with a combination lock with a backup key, and that information was provided to PSWs so that they could go in twice a day to provide her medication. And so that's my scenario. How did you want to proceed from here, Susan?
Yes, I was actually going to now move over to Kim and ask Kim to speak to, from that paramedic perspective, sort of what happens when you arrive and sort of the flow to the hospital, and all of your years of experience to add to the conversation.
Yeah, so I just wanted to explain how a typical call would go, and as I'm doing that, try to hopefully touch on some of Jackie's concerns. But most people probably haven't called 911, or at least hopefully not. But when you do, you'll be asked if you want police, fire, ambulance, and then you'll be directed, obviously, to the ambulance crew if that's what you're asking for. And they'll ask for a brief description of what's going on that day, what the emergency is. And that's what's passed on to us, is that sort of brief kind of, highlight of what the emergency is today. So we'll get dispatched based on that information. And then when we arrive, there's typically 3 ways a call can kind of go. I mean, in general. One way is what we call a patient refusal. And it sounds like, Jackie, it was kind of leaning that way, that your mom didn't want to go to the hospital. And when that happens, we have what's called an aid to capacity. And it's basically a tool that we use. It's a list of questions that we use to assess somebody's ability or, cognitive ability to understand what they're saying no to if they were to refuse transport to the hospital, and whether it's if they understand the consequences fully. If they meet aid to capacity and they still don't want to go, we obviously, like in that case, sounds like with your mom, they worked their magic and they got her to go, which is great. Sometimes we'll spend a lot of time on scene. Sometimes we might even call the community paramedic to come out and see if they can help, or our duty manager. But ultimately, if they meet our aid to capacity and they don't want to go, that is their right to refuse that. So that's where it can get difficult for family. There are cases where they don't meet the aid to capacity and they don't really understand what they're saying no to. That can be difficult as well. But in those cases, we'd use the family to try to persuade. But in worst case scenarios, might even call the police in to see if the patient can get persuaded that way. So that's kind of one example of how a call can go. Another case is where it's an actual emergency. When it's a true emergency, we'll show up with lights and sirens. Sometimes the fire department will be there as well, and that can be it can go from 0 to 100 very quickly and seem overwhelming at times. But things to think about when you call an ambulance is to turn an outside light on, clear a path for the crew, for the ambulance and the crew to get into the home, things like that. Have their health cards ready, their health history ready, including the medications and their allergies, things like that. Have all that ready to go. When you're talking to the crew, try to keep your story brief, specific to what's going on that day, things like that. Oftentimes the family likes to go with the patient in the ambulance, and that's really at the discretion of the paramedic crew. Every call, every situation is different. So that's kind of like a decision that's made in that moment, but you know, it varies. Typically in an emergency, they'll get into a room fairly quickly. And the staff will do at the hospital everything they can do to keep you updated on what's going on. And then they'll try to get you back in the room with your loved one as quickly as possible. So that's kind of how that would unfold. The third scenario is a non-emergency kind of a thing where, unfortunately, in this day and age, it might take quite some time for the ambulance to get there because of wait times and things like that. Everything's kind of getting backed up. But when they do arrive, you know, it's a less rushed sort of situation, less chaotic. They will transport that patient to the hospital, and typically they'll stay with that patient in the hallways or wherever the offload delay is taking place, and they'll remain with that patient until they can be offloaded into the emergency department to a bed, and then that's when the family will be allowed back into the room, which is why that can take some time. And often we'll tell the family just to wait at home for a little while. There's no point in rushing if it's just going to be waiting in the waiting room for an extended period of time. Yeah, so, but in all those cases, things that you might expect to see when they arrive on scene is we're doing patient assessments, which would include our cardiac monitor. We would be getting a set of vitals. We would be getting 12 lead ECG often. We might be starting IVs, giving medications. So that's kind of the things to expect when the crew arrives. Sometimes some of those things are even done in the driveway. So you might expect, oh, my loved one's in the ambulance, get going. But a lot of times it's helpful to do those things in the driveway. We might even be talking to cardiologists directly from the driveway or talking to base hospital physicians right from the driveway. So you might expect to, wouldn't be surprising if you saw us kind of in the driveway hanging out for a little bit longer. But during all of that, we do our very best to make sure we get an extensive history of your loved one. And if there is a dementia or Alzheimer's diagnosis, we do everything we can to explain to the hospital staff what that's all about, so that you know, any aggression isn't mistaken, right? It's or behaviors or anything like that aren't mistaken, and that it's more attributed to like an Alzheimer's or dementia diagnosis. We try to make that as clear as we can before leaving that patient. So that's kind of a very quick synopsis of the progression of the typical ambulance call.
Great, thanks, Kim. That was really, really thorough. Can you maybe just, you mentioned about having information ready when the paramedics arrive. Can you maybe speak to what, you know, from your experience, what sort of format is helpful for you to receive that in, or other tools that people can have ready?
Yeah, so typically, you know, if somebody can have a health card or their meds ready or their allergies and their medical history, if they can have it all in like an envelope or something like that prior to our arrival. But one thing that is really helpful, this is called, depending on the service, some places call it a Kool-Aid card. It's basically just a spot where all their information can be. Their medications, sometimes the medications are too significant. You can just kind of staple them to that little booklet, but it's got your health card, your history, allergies, whether or not they have a do not resuscitate order can be included in there, and the number that goes with that, all in kind of one place. And this actually often, it's got a little magnet on the back, throw it on the fridge, and the crews know to go there first to look for that information, and it's all in one place.
That's awesome. Thanks, Kim. And Danielle has put a link in the chat for a resource that is available through the Alzheimer's Society of Canada. And anything that we're sharing with you that is clickable that you can get digitally, we will be sending out as well with the recording afterwards. And the card that Lindsay was holding up there that Kim referenced, those are not available digitally. You need to, again, speak with your local society, speak with your local paramedic service to get those. But they're happy to provide them. It's a great resource. So now we'll move to Lindsay and maybe talk a little bit about the role of the community paramedics programs to support a patient once they return home.
Yeah, so kind of piggybacking on what Kim just spoke about, Elgin St. Thomas is so lucky to have this new community paramedic program, and we're excited to be here. So how could you end up seeing one of us? You can tell that Kim and I look a little bit differently right now. Kim is also a community paramedic as well, but for today, she's wearing her service shirt and I'm wearing the community paramedic shirt, so that we do look different. So that's kind of one of the first bigger things for everyone to remember, that we come in a little bit more casually dressed. We have marked vehicles, but they are non-emergency response vehicles. So there's no lights and sirens. There's no big to-do when we come. It's less noticeable and hopefully doesn't have all your neighbors staring when we pull in. We're a little bit more discreet from that perspective. So a referral would come from a variety of different ways. You can't just call to get into our program. You have to be referred in. So to kind of piggyback on what Kim's talking about, so if Kim was to be a paramedic on scene and recognize that maybe there was some caregiver burnout, the patient was living alone, there looked like some of his disorganization with medications, maybe they're unkept, any of these things, they could put a referral into our community paramedic program, so that, you know, if the patient and caregiver were willing, we could come in and kind of provide a bit more support. And we have the luxury of having time on our sides. We can spend more time in a home, whereas the EMS paramedics, they got to move quickly. They don't have a lot of time to go through all the notes and all the medications and everything, whereas that's a luxury that we have as community paramedics. So once the referral would come in, we would have a look from our perspective, make sure that the person was a fit for the program, and you can expect to receive a phone call from one of the community paramedics, giving kind of a brief introduction as to what the program is, just seeing if it was something you'd be interested in learning about. Just because we come in doesn't mean you have to accept us, but we always like just to have one visit, just to kind of see if there's anything we can do or that you may need from us. Once, you know, there's the agreement that, yep, great, we would love to have you come, we would schedule a date and time that would work for both parties. Generally, we like to have the caregiver present just to get a better understanding of the patient situation and kind of what the dynamic is. So we can maybe pick up on, is there some burnout? Do you need a little bit more supports? Is what they're saying correct? And those types of things. Is there anything that needs to be filled in? We also have the ability to have a look at patient records as well to get some background information if in the event that somebody is truly isolated and alone and doesn't have that option. So some things to kind of prepare for before we come: we're going to need to see your health card. You're going to need to sign some consent forms with us. Nothing scary, basically just saying, yep, you're good to come in our home and we're happy to share medical information and you're okay with us speaking to other providers on your behalf, and accessing your medical records just to provide better care to you. We're going to need to see those medications, anything prescription and anything that's over the counter. Have them all ready if you have blister packs or if you have a big basket, just have them all together. And your physician's name and contact information if you do have a family physician or a nurse practitioner. As well as, it's always good if you write down any list of questions or things you might want to ask us when we come, because as the visit gets going, things can kind of go all over the place depending on what we talk about. And I wouldn't want you to forget something. So sometimes writing down some questions that we can kind of loop back into, or maybe some goals of things you want to get to, and then we can talk about how we can help get you there. So what's going to happen in the appointment? So the first intake visit is about an hour. It's a longer appointment comparatively to a follow-up visit. And we're going to want to look at like a full health history. the community paramedics are going to kind of look around your house. They're going to look in your bathroom. They're going to look in your bedroom. They just want to make sure that there's no fall hazards. Are there any safety concerns? That kind of thing. So they're not snooping in your stuff or anything like that. It's all 100% safe. They may take a few pictures just so that they can better describe what's going on to other healthcare professionals and other community paramedics who may come out, because our team is bigger, so you might not always see the same person. And we do a full medication review. So depending on how many medications the patient may be on, this may be something we have to come back and do later, but we're looking at what you're taking to make sure that, number one, you're taking it safely, you're taking it right, and you know why you're taking it, or your care provider understands why you're taking that medication. That also helps us to understand, in the example that Jackie gave about her mom, that we would be able to notice if meds aren't being taken, because we've now gone through them all, that if we came for a visit, noticed, oh, they're missing or they're all sitting there, it gives us a good comparison from that perspective. We're going to do a full set of vitals, so you will see the cardiac monitor on that first visit. The community paramedic may do a 12-lead ECG if the patient is comfortable, and that's just to give us a baseline so that we would have something to compare to in the event that something happened and we came out again. We would kind of have that baseline to then share with your physician if needed. And then finally, we would talk about do you have any particular services in place? So when I say services, I mean, the Alzheimer's Society. Do you have home and community care supports coming in? Do you have occupational therapy or physiotherapy? Those types of things. And then is there anything that's needed? So we would have a bit of discussion about that. Hopefully we could come up with a little bit of a game plan before we left. And then the community paramedic would leave our business card, which has our hours and contact information on it, as well as let you know that there would be a follow-up visit, whether that is weekly, bi-weekly, or monthly. We'll determine what the needs are based on each situation. They would come back to the office and figure out what type of referrals they would make based on what happened in that particular visit. So there's a lot going on in that one. That one's longer. We kind of read the room, for lack of a better word. So if we find that it might be too much, they're getting tired, they've fallen asleep on us, we might dial it back and do it in 2 visits. So it really is catered to how it goes. There's no real rules on what has to happen other than the consent forms have to get signed the first time. The rest of it, we kind of go with the flow on how things are progressing. And then there would just be some form of follow-up, which those visits are about 15 to 20 minutes. And we would absolutely be giving you one of these if you didn't have it. And if you required help, we would help you fill that out, because these are wonderful things for our friends on the EMS side when they come and pick you up.
Right, thanks, Lindsay. And just a quick question, and I know you can only speak to the service that you're working with and St. Thomas Elgin. But generally speaking, when someone is being discharged from the hospital, is there sort of a goal or expectation in terms of how soon that initial visit might happen in the home?
So yeah, so it really depends, because we do get referrals from discharge from hospital, but we also get referrals from Alzheimer's Society, home and community care. Our paramedic friends on the road give us referrals. So it really depends on what our call volume is. Likely we're getting back to trying to make contact within 24 hours. And then the visit is based on when they can see us. Okay. And we respect that they have a lot of people already coming into their home potentially, and that can be very overwhelming. And now they're like, now these people in uniforms carrying monitors are coming in. What are you doing? So it's really when we get there so that they understand what the difference is with us coming in versus their PSW versus their OTPT.
Perfect. Okay, that's great. Thank you. So Jackie, I'm going to move to you. Maybe speaking a bit more in depth about just that general emergency preparedness and how social workers like you can help folks to get prepared.
Lindsay and Kim did a really great job of outlining a lot of what I would have suggested with regards to those technical things, right? Their list of medications, their doctors, their medical history, and the forms from. I put the name of the form for Oxford in the chat. It's called the Care Alert Patient Information Card. So having those ready and the form that Danielle shared from the Alzheimer's Society, those are really helpful in, that like I said, that technical part. Also understanding, understanding your person living with the dementia. So, does the hospital scare them? Understanding what their triggers are. Is there a different way if they need to go to hospital? Is there a different way of saying that? For a lot of people, hospital holds trauma and it can be a big trigger. And so, can you think of a way that is a little more creative to say, oh, we're just going to go, we're just going to get some help and we're going to find a way to fix what's going on. And, really provide them with a lot of validation in that moment. They're going to be afraid. They're very vulnerable. We're all, we all feel really vulnerable when we're not feeling well. And because of the dementia, their brain doesn't understand really what's going on. So provide as much validation as you can. Are they somebody that has to go everywhere with their purse and they're kicking up a fuss because they don't want to leave the house without the purse? Take the purse, it's fine. Make sure there's nothing valuable in it. Have things like that you can be prepared. Do they have a favorite jacket that they absolutely have to leave the house in? So knowing, like I said, knowing your person and those little idiosyncrasies that make them who they are can really go a long way. Excuse me, helping them get to a place where they can be supported and feel like they're being, sort of heard and supported in a way that they deserve and understand. If I would say, have the list of phone numbers ready and know who those phone numbers are for. Is it for a son? Is it for a daughter? Is it for a husband, a wife, a sister, whatever that looks like? Somebody who can talk calmly to them and maybe help de-escalate them over the phone. That can be very helpful. I've known that to work with several people from out of country even. What else do I have here? And I think Kim touched on this, a very clear understanding of what the presenting issue is and try to be brief about it. I think that covers everything I wanted to cover. I'm sure, that by no means is this list limited to what we've given you. Again, your person best. How would you, if you needed to take them in that moment, how would you get them out the door? What approach would you use? And so have that prepared. Be really prepared. Have those. You almost need an emergency bag. Like you do when you're expecting a baby and you're getting ready to go to the hospital. You almost have to have the same kind of thing ready for when you have somebody living with a dementia. Having things that they're comfortable with and is consistent in their lives, and people who are consistent in their lives really can go a long way with mitigating any issues that might arise as a result.
Thanks, Jackie. And actually, speaking of an emergency bag, Danielle has just put that link in the chat. So there is information on how to have that packed and ready to go. Especially, if you're supporting someone who, maybe they've had to go to the hospital more regularly, or they're living with a chronic condition and there's that concern. So just having it aside, and that's one less thing that you have to worry about. So with the time that we have remaining, I did want to shift gears a little bit and talk about how this might work, how paramedics might respond, how community paramedicine might support. If it's the caregiver, the care partner is the one that's having the medical emergency. So what does that look like when the paramedic comes to the home, and or if the caregiver happened to be out in the community without the person living with dementia when they had the medical emergency? So how to be prepared for that and how that might be a little bit different. Kim, if you don't mind starting with that.
Yeah, we talked about it earlier, and like you were saying, a plan is the key, right? To have whether it's a list at home there on the fridge or accompanied with the card here, but the reality is oftentimes it's the elderly looking after the elderly in these cases. So you never know who's going to have to go to the hospital, but you would want to have a list of phone numbers ready for like family or neighbors. Make sure that they, know the plan, know where the keys are, know what the code keys are for the door, things like that. Have that all at the ready. Oftentimes when we get there and if we're taking the caregiver to the hospital, leaving the person with dementia or Alzheimer's at home, it's kind of a struggle. Sometimes we have to call the police to come and sit. There are rare occasions if we have time and it's feasible, I have in the past taken both to the hospital, but that's kind of challenging and we don't really like to do that, but it has been done. But the best thing is to, have a plan in advance of who to call, who can come sit with that patient. Worst case scenario, like I said, the police could come until we can get something else in place. Sometimes even community paramedics can go out if it's possible, but that's kind of hard to know. But main thing is to have a plan with those numbers.
Great, thanks, Kim. And we will share, there is a great kind of card from our friends actually in the UK that we can include as a printable resource. It's basically something that you can keep in your wallet. And that way, if the paramedics come and you're away from home and they can see that and they're like, oh, this person's caring for someone at home and now we need to know, have somebody go and all of that information is on the card about who to contact. So that way, if the person's caregiver is going to the hospital, the person living with dementia is not left at home endlessly, not knowing what's happening. So we will include that as well. Lindsay, if you're able to speak in terms of community paramedicine, I know you had shared with our group a really great example about how that can kind of come together with some of the partners involved.
Yeah, so in community paramedicine, we really do get a lot of more interaction with the caregivers and the patients, and we develop fairly good relationships with them and they trust in us. So there's two situations I can think of. Number one is we all know the caregiver burnout. Caregivers don't always take care of themselves. And then, something, even not so much an emergency, but a planned, like a caregiver who needs to get a hip replacement, but they're scared to get the hip replacement because they're not sure what's going to happen to their loved one when they're gone. So, what options in that situation, what options are there? And again, I mean, looking at when you can plan something, it's a lot easier than trying to do something in that moment in the emergency. But some examples would be, working with a community support, so home and community care. Can you get some more care in? Can you plan to have family that could come and stay? Is there a respite bed that maybe your loved one could go to for a short duration of time so that you don't have to worry about that while you're, attending to yourself? And then, we can be brought in to help with, more frequent visits if, they just need some reminding and such. The other option would be, something emergently happens, you need emergent surgery, something has happened and now there isn't that time to get a respite bed in place in that moment. And it's Friday night and, what are we going to do? So, since we've been here, we have worked in a situation like this for a client, and with home and community care, we surrounded them with multiple appointments per day, just making sure that the patient had their insulin and that they were eating. And then we made sure a neighbor was walking their dog, because remember that animals could be very important, or they might have something else in their home, their plants, you've got to really figure out how do you bring that stress down so they can take care of themselves and have a better recovery so they can be better for their person, right? So, we got a neighbor to walk the dog. And when we were there, we would, do the insulin, make a little meal, take the dog out, come back up, see you in a couple hours. Luckily we had the ability in that weekend to work with home and community care to do it. So just a couple examples, but the big thing is that you can't ignore your own needs, and that there are resources out there to help you support your loved one while you are getting care.
Right. Thank you, Lindsay. Jackie, if you can just build on that. I know I kind of scooped you by talking about that card, but just kind of stemming from what Lindsay was saying about really, again, the importance of caregivers, taking care of their own needs and how to be prepared for an emergency.
Well, I echo what Lindsay said. You know, I made a note while she was saying this, that these are the conversations I have with care partners. Is you're the sole care partner, and I know that you take that very seriously. And what do you do? What's your plan if something happens to you? You know, who's your backup? I really work. I'd like to create some kind of form so that, or a checklist if we don't already have one, to go through those things that Lindsay talked about. If there's a pet, you know, is there respite available? Is there a family member that they can call in for backup? Do they have their own medications, a list of their own medications? Do they have their person's medications? Like all of the things that we've already talked about. Again, that planning piece is so imperative to that journey. And I don't know that I can add much else to what's already been said. Sorry.
Thanks, Jackie. I know, yeah, we appreciate you being involved when your throat is so sore. And we want to get to our questions, but actually the questions that have come in, I think, Lindsay, speak a little bit to the community paramedicine program. And I was going to ask you to sort of speak at a high level about, you know, what that looks like in terms of referrals, at least for how they work for you. And I think I just bring in a couple of the questions, again, around how community paramedicine is different from nursing, and other examples of referrals or services to provided for the best use of the community service. So those are two that are kind of tied together, I think.
Yeah, so I guess it's really important to note most all paramedic services here in Ontario do have community paramedic programs attached, but it's really important to note that they all kind of function a little bit differently. So what someone might do in London or Oxford or Ottawa could be different from what we do here in St. Thomas Elgin. So when I'm speaking just specifically on what we do here in St. Thomas Elgin. So a referral. So referrals can come, as I kind of touched on earlier, need to come from a healthcare professional. So whether that is a primary care physician, a nurse practitioner, hospitalist, Alzheimer's Society, one of the other community supports, home and community care, they come through that way. And then we do a review of, you know, is this something we do? So kind of leading into that, what do we do? So I'm going to keep it very high level. But basically we do routine monitoring just to get a measure on whatever the chronic disease somebody's dealing with. So we work closely with each individual's primary care practitioner to help keep them safe in the home. I mean, like we've talked about, no one wants to go to the hospital. And when they do, it's, you know, it's hopefully not because we couldn't have done something in the home first. So, you know, whether that be they have COPD and they, you know, they're starting to feel a little short of breath and maybe they're starting to cough up some sputum, working with the physician to get an action plan to help put in place to get them stuff they need at home. That's just one example. We do 12 leads and we use other different types of assessment tools to determine, you know, where somebody is in their disease process. We have the ability to put in some remote patient monitoring, which is monitoring equipment that sends us the vitals remotely, and we can keep an eye on people's weights, blood pressures, heart rates, and O2 sats, and just kind of build trends if we see something going on. So that's another thing. We are just going to be starting in the palliative care space with the palliative care outreach team in the upcoming months. We do some minor wound management and we work with home and community care on that stuff. We do vaccinations for homebound individuals. And really, we are just another community partner collaborating together to try to keep people, you know, home, safe, and with what they need. So we aren't nursing. but we are an addition to the home care team to provide another perspective and another skill set. Does that answer?
Hopefully that answered it. If not, for those who asked the questions, please submit again. There is a, just as we move into our Q&A time, there's a question about why, or maybe a scenario in which a paramedic might keep a family member from going in the ambulance to the hospital with the loved one.
Yeah, so we talked about that earlier, and again, it's at the paramedic's discretion typically, but when you've got somebody that's quite serious, having a family member there can be problematic for a couple of reasons. Number one, sometimes their emotions can run a little high. They can be a bit of a distraction. Sometimes there's things that they're not going to want to see. It's not the most controlled of settings. They're often much better off getting into the room once they're in the hospital and things are a little more stable, things like that. It's just safer overall for the patient to be transported, and the paramedic can give their sole attention to that patient versus, you know, a distraction. And so typically that's kind of the way we like to do it.
Great, thanks, Kim, for clarifying that. There's a question here. I'm not sure if it's going to be the scope of the panel, and perhaps the person who submitted it could provide a bit more detail if needed, but it mentions that there's a family that's being asked to consider, I'm thinking it means a DNR for both parents who are late 70s, early 80s, and they're both in general good health. Any thoughts from the panel about this? Maybe about the use of the DNR and when it's recommended or how that works. Oh, you're on mute.
So sorry, from our perspective, it's really just a way for someone to express their wishes on how much care they want to provide. There's no, is there a good or bad time to them? No. There's, you know, certain times where a physician or a care provider may bring that up because of what's going on with an illness, to make sure that somebody clearly understands what each of these things mean. Because sometimes when people say do everything you can, they don't understand what CPR really is and what it really looks like and what it really does. You know, what does it look like being on a ventilator? What does it mean if you go on a ventilator? Will you come off the ventilator? So, and there's also important to know there's different things you can choose. So there's not just like it's one-stop shop. If you sign it, you don't get anything. There's different options. So I think it's important for people to be aware of them, aware of what the options are and what each thing means. Because from our perspective in the 911 world, there's nothing worse than doing CPR on somebody that it's a futile resuscitation and it's quite traumatic. So it's just important to understand what all those things are. I don't think you have anything to add to that, Kim?
Great, thank you. And Jackie, I don't know if you can maybe share if you've had some of these conversations with clients, just at a high level about what those conversations might look like and kind of building on what Lindsay has shared.
Yeah, I have had these conversations with care partners. They're never comfortable conversations to have, but I remind them that it's really important that they know as soon as they can what their person wants, you know, and if they know what that is, to make sure that they have it in writing somewhere so that they can refer to it. Because when we get busy and we get caught up in the chaos of an event like what we're talking about, like things get forgotten very easily. And so I try to have a conversation about where to include it in their plan for their person. As I said, they're not easy conversations to have. And I do my best to approach them with kindness and as gently as I can, and preemptively say, I don't want to have this conversation, but it's definitely part of the journey that everybody goes through. And I've got one signed already, and my kids know what my wishes are. And, you know, I really try to make it a human approach. Some people are like, oh yeah, you know, I never thought about that. They're really on board. And other people are like, I'm not even thinking about that right now. Why would you even ask me? So, you know, and then we revisit it later. So yeah, those conversations are happening, and it's important to have them as gently and kindly as we can.
Right, thanks, Jackie. And I think I saw a reaction from Lindsay and Kim when you talked about that. You're so prepared, yes, but I think it really speaks to yeah, and we don't
What was
often
that,
think about
Lindsay?
it.
Sorry, what was that?
Your both were like, do you have yours signed yet?
When I started this job, all that paperwork got done.
Yeah, and it really, to any of us, right, to make sure that those around us know what our wishes are. So maybe, Lindsay, maybe just a bit of a clarification. I think you spoke to this a little bit earlier, and I know that you can only speak specifically to the referral process in Elgin St. Thomas, but in terms of what that referral might look like for an assessment to enroll in the services.
So sorry, do you mean like what I would do once I realize I need something else from somebody else, or do you mean into our program again?
Into your program. So yeah, how do we get a referral for an assessment to enroll in their services?
Yeah, so just, you know, if you were, you know, because we're new, a lot of the practitioners don't know about our program, but it's getting more widely known. I do have an information package that I do send out to primary care providers. And so if you have that discussion saying, you know, I heard about this program and maybe it's something that's a fit for me, the physician or practitioner, whomever it may be, will be able to send us a referral directly to us. And then we would have particulars to then make that phone call. You know, our criteria for being in our program, we do primarily focus on people like that are on a long-term care wait list or crisis list. We focus on people who may be soon to eligible into that, or people who have been assessed and are waiting to get on the list. So kind of a big parameter of things, but at the end of the day, the main thing is to keep those out of hospital and home and safely for as long as they can, working with the other providers in the region.
Wonderful, thank you. And again, if you're in a different region and you're not sure how to access the community paramedicine program, certainly speak with your support worker and they can look into that for you. And just, I know there's a question about the form for DNR. Certainly, again, I would recommend speaking to your support worker. They can help you get directed to the pathway to do that. There is one last question that I wanted to bring forward. I think it's a really good one. Again, this is to Lindsay and Kim, probably more to Kim. Can you speak more to how a paramedic or other medical professional would work to differentiate between behaviors of the person living with dementia versus another mental health concern, including illness or hospital-based delirium?
Well, I mean, obtaining a good history is finding out, you know, what if they've been diagnosed. Can you speak to how?
Yeah, so I guess, like, you know, it'd be really important to have people around to get a baseline for what they were before. Where was the sudden change? Is there anything else going on? You know, because from a medical perspective, acute delirium is obviously an emergency, but, you know, thinking about, is there some kind of infection? You know, do they have a urinary tract infection? So kind of going the medical route to see if you can see anything that may lead you to something that's created that acute onset. Understanding what their history is and what their baseline is and where they are now and how quickly they got to that. So sometimes in the 911 world, it's a lot harder to do it because you don't have as much time. Where in the community paramedicine world, we have more tools at our disposal. So we can do a urine analysis on somebody to see if, you know, there might be an infection. We can spend a little bit more time with them. We can call other practitioners to get more information on them. So I think it really just depends on what the situation is and what the crisis is in the moment.
Great, thank you. And so we're just going to be wrapping up here. I'm going to share my screen again for a moment. go. Hopefully I'm sharing the right screen. Excellent. So I did really want to thank Lindsay, Kim, Jackie. Thank you so much for making time for this. And I know we had some pre-work to get here, and really think the discussion is really valuable, and hopefully will stimulate some more discussion and get people to ask some really good questions with their healthcare providers and with their support workers. And to our attendees, thank you so much for joining us today, and we hope to see you in November, which will be our next Brain Matters webinar we'll be working with fire services, so that'll be our next topic. And oh, we've done that already, and it's November 22nd, so again, save the date. If you are not already signed up for our newsletter, we encourage you to do that. You'll get notified of all of our upcoming events.